So we are hearing a lot of things like smile, silk, and it's very, very confusing to many of us. So Dr. Wavikar is going to clear the myth about Contoura vision, how effective it is, how good it is. Dr. Wavikar, please.
Do you have a pointer? Pointer है क्या? Thank you everybody, and thank you Dr. Vinod Arora for giving me this opportunity to be a part of a very good instruction course. I am going to talk on Contoura, no financial interest. Now we started LASIK in 1990 early, and there were a lot of problems like this. And people started thinking, what is the problem? So there were problem was in the excessive amount of higher order aberrations. There were two reasons basically. Number one is those which are pre-existing, and the one which are induced by laser. For the ones which are induced by laser, so many things happened: improvement in flap creation, laser machines, and ablation pattern. Whereas in pre-existing treatment, we had wavefront guided, then FCAT, and topo guided. But soon it was realized that wavefront guided is only for around 5 to 10% of the patient, because actually people do not have that higher aberrations. FCAT now, it is restricted to presbyopic correction, and topo guided was mainly looked at as a reparative process whenever there is something has gone wrong. So what is the problem with topo guided? The number one is that getting reliable and reproducible reading was very, very difficult. So, and therefore we used to struggle with the kind of treatment we want to give. Now we have Vario, the machine which gives us very, very accurate reading. We'll come to this in ahead. Second is inability to estimate the refractive effect. Now just imagine that on one side 15 microns are getting corrected, ablated, on the other side 13, in the superior part 12 and 19. So you don't know what the refractive effect is, and therefore we used to get struggle with this. Now we have got proper mathematical robust calculating nomograms, and therefore it is possible to predict the results. So basically Contoura is topo guided, but in new avatar. What are its unique features? Number one is that it treats HOA as well as refractive error. Number two is that the treatment is centered on the corneal apex. Number three, it does aspheric treatment also, so takes care of the Q value and cyclotorsion, and shorter ablation time because it treats cylinder and sphere simultaneously. So what is the benefit? Patient has excellent quality of vision. Somebody has to start doing Contoura to believe in the result. All these things are the past. And this is what the FDA results said, that you look at this, 34% of the patient achieving vision better than 12.5, and 65 are better than 2016, and so on. And the same result explain that there are hardly any side effects. Now, but we will not, get proper result unless we have done proper pre-op workup and proper calculation. There are no shortcuts here. So the workflow is like this, that first the readings are taken on Vario machine, and then they are sent to the workstation, and then to the ablation machine. We need to capture high quality measurements, and therefore dryness, position of the patient, position of the ideal image, how to do, nose comes in between, and capture 8 high quality image. Now this is what the thing is, that you can see the two red, see, one is a preferred and second is R is registered. And then these three, optical zone 6.5, 100% data. And then this is a valid for registration. All these things are important. It is also important to look at this map properly to understand lot of finer things which I cannot explain now. So 4 high quality image, scans with best tear film. So we have to take the reading before the tear film starts breaking up. And therefore it is very essential to understand what is the Tibet of the patient. And reproducibility by understanding the differences not more than 0.35, and P and R I have explained. Now this is what I was talking about, reproducibility, that these are the 4 maps, and this one on the side is the difference map. So this is the difference between C and D. You can see C and D is highlighted, and you see the central pupillary area. If the difference is more than 0.75, these two maps are not matching. Now, to be more critical, we prefer 0.5 only. Alcon guidelines are 0.75, but we go by 0.5 guidelines, and believe me that with repeated training and insisting on quality, it is possible. You get at least 4 such maps. So these 4 maps are sent to the planning station. So up till now we were at Vario, now we go to the second stage, and all these things are checked: K values, axis, Q values, pupil size, and MAD. So I'm sorry, I have to turn around. So you check that it is a raw Sajalta data, Q value, MAD, that is what is the difference, and the pupil size and the axis. All of these should be matching. Also look at the star. This is the reading which is going to be used primarily for registration, and the pupil should not be too off. It has to be somewhere in between. Once you start taking all these precautions, you start doing well. Then comes the adjustment. What we have to do is that we have to put 0 in the refraction. Whatever map is left, it is treating only higher order aberrations. We have to understand what is the refractive effect of higher order aberrations. And once done that, then you take care of the cylinder, and then you take care of the sphere, ensuring that the spherical equivalent is constant. Now, in this, you see that first thing what I am going to see is, I have put 0 here. So this is only a map of higher order aberrations. Now, you can see that the difference here between the central and the peripheral ablation is only 3 microns. This is acceptable. The difference has to be 3 microns. Or you can click on Zarnike and C4, C12 compensation. Whatever is the value of C12, 2/3 of that, if you add here, you will get C4, and C4, C12 will be equal. They should be of opposite sign. Most of the times you have to feed minus, because you know aberrations are in the periphery. Now once done that, we need to check the axis, where the axes are matching, and then if required, you reduce the optical zone. Okay. Once done that, you take care of the cylinder. There are different rules. If the cylinder is less, what to do, cylinder is more, what to do, and then you adjust the sphere in such a way that the spherical equivalent is constant. Once you do that, it looks very complicated, but you do 20 cases and you will be a champion. This is the Alcon nomogram. I will not go into detail, but I will show you by examples. Again, at the time of ablation, it is very important to follow all the rules. Patient positioning is important. If the patient's head is lying underneath the machine, but his legs are on one side, he is going to get cyclotorsion. We don't understand these points, but so that is important. There are red crosshairs which we keep and see that both the eyes are aligned along the horizontal red hair. And therefore, registration has to be done. Registration can be bypassed, but it is not a good idea to bypass, because it does not. It takes care of cyclotorsion. Now imagine that somebody has got a aberration like this, and because of cyclotorsion, instead of treating like this, you treat like this. What is going to happen? You are not going to get a good result. So registration is a must. And the benefit over wavefront optimized LASIK is that you have to compensate for angle kappa manually 75%, which is arbitrary. Over here, it is absolutely in whatever microns. And then the pupil size at the time of registration and at the time of treatment has to be same, because you know that as the pupil changes size, its center shifts, and therefore we want, wherever the registration happens, we want the center to be over there only. So you register first, remove the flap, take amount illumination to the exactly same level, and then fire, and believe me, you will get a good result. It is also important to check whether the patient was fixing properly. Now this is a reasonably good fixation. If the fixation is poor, we will get good result, but the recovery will be slow. So somehow I have come to believe that if the patient is 6/6 on day 1, that means it's a good LASIK, very, very well done LASIK. If the patient is not 6/6 on day 1, eventually within 4, 5, 8 days, patient will become 6/6, but body is adjusting. It is not a perfect LASIK. So now suppose you in first case you did not get a good fixation, then with a device you can fixate the eye, so that you will get a good thing. Now let us see some of the examples. I can stop whenever we want. Now we have a situation here where the you can see this is 7 and 3, so difference of 4, so that is not acceptable. So I will have to enter something here. I entered minus 0.10, the difference had become now 3, acceptable. Then I concentrate on the cylinder. If the subjective cylinder is more, enter as it is. The difference between the axis is not significant, very good. So I'll enter minus 1, and this 0.1 will be added to 4.5. So our treatment will be 4.6 minus 1, 30 degrees. It is always the subjective axis we are going to pay. Now the subjective cylinder is same as calculator cylinder. This is one of the simplest cases to do. You can see, but the difference over is 10 and 5. So I'll have to add something here to compensate for the refractive effect of the higher order aberration treatment. So 0.15, and then 1.5 will be here, 3.5. So this will become 3.65. So 3.65, 1.5, and so on. Now we have an example where the subjective refraction has no cylinder. Sometimes you get a situation where there is no cylinder, but the calculator or the higher order aberration is showing a cylinder. Now you look at the map. Obviously one treatment is getting here. Obviously this is inducing some cylinder, and that is why that cylinder. Respect this cylinder. We cannot ignore this. Once you start respecting, you will get a good result. So first I entered minus 0.1 here, because there was a difference down below. Half of that I entered here, and half of this in opposite direction. So I will have to, instead of 38, I will have to add 19 here. So it will be plus 9. So 3.25 plus 0.09, the treatment will be 3.16. You go like this. This is Alcon nomogram, and it works very well. Now there are some cases where Contoura is not recommended. You are not getting good maps, and there is too much of difference between the axis of the cylinder, and there are many examples. Keratoconus, what we do is that we become liberal about this, MAD and axis and all this, and we just put 0 here and treat, only ensuring that your treatment does not cross 40 microns. So over here I am treating only higher order aberrations. I am not worried about the refractive error. Now Forsitis is it is not legal, but unfortunately it works fantastic. There are some cases where calculation in Contoura becomes a headache. This is the time Forsitis is like cakewalk. So it is an analytic engine. It improves accuracy of topoguided LASIK. What it does is that it identifies 3 prominent talus, we call this talus, and their mathematical effect. And it comes in this shape, in this form, tabulated form. And there are 4 basically origins of cylinder in the eye: anterior corneal, that is K reading; topographic, that is what you are seeing here; posterior corneal astigmatism, and internal astigmatism. Sorry. So it has studied the the taluses and given the refractive effect properly. And the outcome comes like this. All the 4 cylinders are represented, and what is the recommended treatment? You just feed it in your excimer laser and fire, you will get a beautiful result. So it is more advanced than a simple nomogram. It is much faster. It takes only 10 seconds and a better post-operative result than other methods, meaning the Alcon nomogram. But in cases where Alcon nomogram sounds dubious. Thank you very much.
Very nice, sir. This the Contoura vision is centered on the pupil, or
It is centered on the corneal vortex.
vortex? What is vortex? Just to perform.
So basically, there are 3 points we have to consider. One is the center of the geometric center of the cornea, that is the corneal vortex, and pupil center, and the line of sight where it intersects the cornea. These are the 3 points. Over here, angle kappa, everything is not important because it is just centering its treatment on the corneal vortex. That is because Our topo readings are taken on corneal vertex, but it has an added advantage. We don't have to bother about adjustment of angle kappa.
And second, would you recommend Contoura for most of the cases?
Yeah, sir. Yeah. So there are some cases where Contoura is not advised. If you are not getting good maps, or if the difference in the axis of the cylinder, calculated and manifest cylinder is quite a lot, if aberrations are very high, that means sometimes you get 19 microns of ablation. So I would better not do play with that. I'll just do wavefront optimize. However, our confidence is increasing, so we are doing more and more cases to Contoura.
That means routinely you are doing most of the cases.
Yeah, around 98%.
And secondly, Alcon is coming with Wavelight Plus. That will be the combination of topo guided plus wavefront. Do you think it will improve the results further?
I had I was fortunate to see their Innovoice machine when we had gone for ASCRS, and the way that engineer explained, it looked like there is a significant jump over Contoura. However, looking at a cake and eating is different.
That's right. See, wavefront ablation, if you leave the cornea, they are very minimal. Hardly occurs in 3 to 4% of person. Most of the ablations are limited to cornea. But of course, that will add further to it, further refine the things. Thank you very much.
Yeah, there's one more point I wanted to say is that Contoura works far better in advanced surface ablation. The results are even better than LASIK. So, we are very eager to listen to you.